We're really excited to have you and talk about a really important topic for our education as we are launching into the second half of August, which is surgery. Surgery is something we get asked about a lot. Surgery is something that we know is important to all of you. So we have brought along today Dr. Brandon Chapman to a presentation on this current colon and rectum surgery options that are available, what's emerging, and everything else that you need to know. So before we get started, just want to let you know about questions. Put them please in the main chat. There's also the option to do a Q&A tab, but for whatever reason, we can't see that on our side. So just put it in the main chat box if you could. And then once Dr. Chapman is done with his presentation, we'll be happy to get to your questions here. Then in the webinar archive, if you want to watch any of our pre-recorded webinars from the last years, then please head over to our fightsarc.org, check out our resource library and search by webinar. You'll be able to find every other one that we've done and recorded. And then also feel free to tweet along. You can use the hashtag CRC webinar and connect with people through there. This is just a couple of the examples of the things you'll find in our resource library if you want to head over there while you're looking for other webinars. We also have mini magazines covering a variety of topics that dive deep into things like side effects and genetics and screening, many of the other things you could be interested in. We also have many fact sheets, including what you see here about facing a diagnosis of colorectal cancer. And we also have our Beyond Blue magazine, which is our biannual magazine that we come out with. Just about to release the fall issue of it. We're really excited about that. So keep your eyes peeled for when that's coming out, all right? And just to let you know, as a common disclaimer here, the information and services provided by Fight Colorectal Cancer are for general informational purposes only. The information and services are not intended to be substitutes for professional medical advice, diagnosis, or treatment. If you are ill or suspect that you are ill, please see a doctor immediately. In an emergency, call 911 or go to the nearest emergency room. And Fight Colorectal Cancer never recommends or endorses any specific physicians, products, or treatments for any condition. All right, and now for the main event. Thanks again, Dr. Chapman, for joining us today. And sit tight, because this is going to be an exciting one.
Hi, my name is Brandon Chapman, and I'm a colorectal surgeon at the University of Colorado Hospital in Aurora, Colorado. I'd like to thank Mike for allowing me to present this webinar today. It's an honor to be here, and I hope to provide you with some useful information that'll help guide you through the workup and surgical treatment of colorectal cancer. Today, we will briefly discuss the current statistics on colorectal cancer, what colorectal cancer is and how it spreads, presenting signs and symptoms of colorectal cancer, how it is diagnosed and staged, the surgical approach to treating colorectal cancer, the risk of surgery, and the recovery process after surgery. I would be happy to answer any questions you may have at the end of the webinar. Overall, the lifetime risk of developing colorectal cancer is about 1 in 23 for men and 1 in 25 for women. It is the third most common cancer diagnosed in both men and women in the United States. The American Cancer Society estimates that there will be greater than 104,000 new cases of colon cancer and greater than 45,000 cases of rectal cancer diagnosed in the United States in the year 2021. Colorectal cancer is the second leading cause of cancer-related deaths when men and women are combined. It is expected to cause over 52,000 deaths in the year 2021. So what is colorectal cancer? Colorectal cancer is a cancer that starts in the colon or the rectum. The colon and the rectum are often grouped together because they have many similarities, but as we will discuss later in this lecture, there are some key differences in treatment. The colon is part of the large intestine and consists of 4 sections as shown in this figure. The first part is the ascending colon, which includes the cecum and the appendix. The next portion is the transverse colon, then the descending colon, and then the sigmoid colon. The sigmoid colon connects to the rectum, and the rectum connects to the anus. So how does colorectal cancer start? Most colorectal cancers develop as growths on the inner lining of the colon or the rectum. These are called polyps. This figure shows a picture of a polyp in the transverse colon. Some of these polyps are precancerous, and if they are not removed, they can develop into cancer over time, which is why screening colonoscopies are so important. They can prevent colorectal cancer. How does colorectal cancer spread? If a cancer forms in a polyp, it can grow into the wall of the colon or the rectum over time. The wall of the rectum and the colon are made up of many layers as shown in this figure. The cancer begins forming in the innermost layer called the mucosa, shown here as well as here. As the cancer grows, it can grow outward through the other layers of the bowel wall. When the cancer cells are located in the wall of the colon and the rectum, they can grow into blood vessels or lymph vessels that carry waste away from the colon wall. Once the cancer develops in these vessels, it can spread to other parts of the body. The stage of the cancer is determined by the extent of spread and will impact the treatment options available. It may be localized to the colon, it can spread to adjacent lymph nodes, or it can spread to other areas of the body, such as your lungs and your liver. What are the signs and symptoms of colorectal cancer? Patients most commonly present with a change in their bowel habits, and this may include diarrhea, constipation, or a narrowing of the stools. Patients with rectal cancer may have a feeling of having a bowel movement that's not relieved by having one, having rectal bleeding or blood in the stool, cramping or abdominal pain, weakness and fatigue, or unintentional weight loss. So how is colorectal cancer evaluated? Your doctor will ask you about your medical history and the possible risk factors for colorectal cancer. Your doctor will perform a physical examination evaluating your abdomen for any masses, as well as a rectal examination. Your doctor may order stool studies to test for blood that is not visible to the naked eye. Your doctor might order certain blood tests. A complete blood count, or a CBC, measures the different types of cells in your blood. It can show if you had too few red blood cells, called anemia. Some patients with colorectal cancer become anemic because a tumor has been bleeding for some time. You may also have a blood test to check your liver function, since colorectal cancer commonly can go to the liver. Colorectal cancer cells also make substances called tumor markers that can be found in the blood. The most common tumor marker for colorectal cancer is called CEA, so your doctor may check for this. A colonoscopy will be performed to evaluate for any cancer in the colon and the rectum, and if a mass is seen during the colonoscopy, it is biopsied. A biopsy removes a small piece of the tissue with a specialized instrument passed through the colonoscope. The biopsy will be sent to the pathologist, and they will look at it under the microscope to evaluate for cancer. If there is cancer, they may send some additional genetic testing. So what happens after you are diagnosed with colorectal cancer? After someone is diagnosed with colorectal cancer, doctors will perform additional tests to try and figure out if it has spread, and if so, how far. This process is called staging. The stage of the cancer describes how much cancer is in the body. One of these staging studies is called a CAT scan, or a CT scan, also called computed tomography. A CT uses X-rays to make detailed cross-sectional images of your body. This test can help tell if the cancer has spread to other areas of the body, such as your liver or your lungs. For rectal cancer, additional studies are ordered to look at the area around the rectum for signs of cancer spread. This is most commonly an MRI, but an ultrasound can also be performed. These two studies will help guide decision-making if surgery is to be performed first, or if the patient should receive chemotherapy or radiation prior to surgery. What are your treatment options after diagnosis? There are a variety of treatment options, and it is dependent on several factors, including the location of the cancer, the stage of the disease, and the presenting symptoms such as a bowel blockage. Local treatments treat the tumor without affecting the rest of the body and include surgery to remove the cancer or radiation therapy to try and kill the tumor cells. Systemic treatment includes chemotherapy, which can be given by mouth or directly into the bloodstream to reach the cancer cells throughout the body. There are a variety of drugs that can be used, and most are fairly well tolerated. Surgery is often the main treatment for colon and rectal cancers that have not spread to other areas of the body, like the liver or the lungs. The type of surgery used will depend on the stage of the cancer and where it is located. This figure shows the entire colon and the rectum, as well as the blood vessels in red and the lymph nodes in green that supply the colon and rectum. The goal of surgery is to completely remove the area of the colon and rectum with the cancer in it, as well as these lymph nodes that drain the area of the colon or the rectum. If it's decided you need to have surgery, what do you do before surgery? The best thing you can do for yourself prior to surgery is to stay active and engage in regular exercise. I like to think about it as surgery being similar to training for a marathon. You want to train for the surgery to improve your post-operative recovery process. You should try to eat a well-balanced, healthy diet, as your body needs good nutrition to heal from the surgery. If you smoke, you should stop smoking. The day before surgery, you will need to complete a bowel preparation that clears your colon of stool and will also likely be given some antibiotics. Both of these will help reduce the risk of an infection. You'll be instructed to consume a clear liquid diet 24 hours prior to surgery, and this is usually continued until 2 to 4 hours before the surgery. How is surgery for the colon and rectum performed? There are a variety of techniques that can be done to remove the colon. Open surgery is when the surgery is done through a single long incision in the abdomen and is shown in this left upper figure. Minimally invasive surgery uses smaller incisions and specialized tools to remove the colon or the rectum. There are two different ways of doing minimally invasive surgery and include laparoscopic surgery and robotic surgery. Examples of some incisions for laparoscopic surgeries are shown in the right upper figure, and the bottom picture demonstrates robotic surgery. Minimally invasive surgery offers many advantages, including less pain after surgery, a faster return to having bowel function, and shorter hospital stays. However, not all patients are candidates for minimally invasive surgery, so you should discuss this with your surgeon. What type of surgery do we do for colon cancer? It depends on where the cancer is located. A segmental colectomy, also called a partial colectomy or hemicolectomy, is done to remove the part of the colon where the cancer is, as well as at least 5 centimeters of normal tissue on either side of the cancer. The lymph nodes draining that segment of colon are also removed as part of the surgery. The figure on the right demonstrates the colon with different locations of cancer highlighted in dark blue. The area of colon that will be removed is highlighted in light blue. Once the cancer is removed, the pathologist will evaluate the cancer under the microscope to determine the extent of the cancer. They will specifically look at the lymph nodes to see if there's any cancer in these lymph nodes, as this is one of the most important factors in determining the need for chemotherapy after surgery. A total colectomy removes the entire colon, but is rarely needed for colon cancer. It is mostly used if there's another problem in part of the colon without cancer, such as someone with hundreds of polyps in a genetic syndrome, or sometimes in patients with inflammatory bowel disease. A common question when discussing surgery is, will I need an ostomy bag? Typically, for colon cancer, you do not need to have an ostomy where stool will drain into a bag. Usually, after removing the cancer, the two ends of the bowel can be reconnected back together. This is called an anastomosis. There are a variety of techniques to create anastomosis and may be hand-sewn with suture or more commonly with a surgical stapler. The figure on the right is an example of a colon cancer in the sigmoid colon. The area highlighted is what is removed and includes the blood vessels and the lymph nodes draining that area of the colon like we previously discussed. After the colon is removed, the picture on the right shows that the two ends of the colon are connected back together. The treatment options for rectal cancer are a little bit more complex than for colon cancer. Rectal cancer will frequently require radiation or chemotherapy prior to surgery, although this will depend on the extent of the cancer. There are a variety of ways to give radiation and chemotherapy. Although surgery is still the main treatment for rectal cancer, sometimes the cancer will completely go away after radiation and chemotherapy. In this situation, sometimes surgery can be avoided, but requires very, very close follow-up to make sure it does not recur. What surgery do we do for rectal cancer? The type of surgery performed for rectal cancer depends on several factors. It will depend on the stage of the disease, where it is located, and whether the muscles around your anus, called the internal and external sphincter muscles, are involved. These sphincter muscles are important in holding stool until you are ready to have a bowel movement. This figure demonstrates the internal sphincter as well as the external sphincter surrounding the rectum and the anus. Transanal excision can be used to remove some early stage 1 rectal cancers that are relatively small and not too far from the anus. The advantage of this procedure is that it avoids incisions on your abdomen. In this procedure, instruments are inserted through the anus into the rectum, and specialized tools are used to remove the cancer. The surgeon will cut through all layers of the rectal wall to take out the cancer, as well as some surrounding normal rectal tissue. The hole in the rectal wall is then closed. Sometimes additional treatment with chemotherapy, radiation, or additional surgery may be required if the cancer has grown deep into the rectum, was not completely removed, or has signs of spread into the lymph system or blood vessels. Some stage 1 rectal cancers and most stage 2 or 3 rectal cancers in the mid to upper rectum can be removed by what's called a low anterior resection. In this operation, the part of the rectum containing the tumor is removed along with the nearby lymph nodes and other tissues around the rectum. The top left figure demonstrates removal of the rectum and the tissue surrounding it. The lower part of the colon is then attached to the remaining part of the rectum, as seen in the right upper figure. This allows the patient to move their bowels in a normal way. However, if radiation and chemotherapy was given prior to surgery, a diverting loop ileostomy is frequently performed. This is where the end of the small intestine prior to the colon is connected to a hole in the skin of the abdomen, as shown in this bottom figure. Stools then come out of this opening. An ostomy bag that sticks to the skin is then placed around the stoma to hold the stool. This gives the rectum time to heal before stool moves through it again. In most cases, the ileostomy can be reversed about 8 weeks later. An abdominal perineal resection, or an APR, is more involved than a LAR as previously described. It is needed if the cancer is growing into the sphincter muscles as seen in this figure. The sphincter muscles help keep the anus closed and prevent stool leakage. Because the cancer involves the sphincter, they will need to be completely removed along with the anus. In this surgery, there are incisions in the abdomen as well as around the skin of the anus. This allows the surgeon to remove the rectum, the anus, and the tissues around it. Because the anus is removed, a permanent colostomy is needed, as shown in the right upper figure. What if the colon is blocked or the rectum is blocked? Some cancers may be large enough to block the colon or rectum, resulting in a bowel obstruction, and surgery may be needed right away. In this setting, the bowel is removed as previously described, but instead of reconnecting the ends of the colon or rectum together, the top end of the bowel is attached to the skin with an ostomy. Can the ostomy be reversed? Typically, the answer is yes, but every patient is different and you should discuss this with your surgeon. Reversal of the ostomy requires a second operation to put the two ends of bowel back together. Typically, we wait 2 to 6 months after the initial surgery where the ostomy was made, which allows the patient time to recover from surgery, get healthy, and complete chemotherapy if needed. How do I learn how to take care of the ostomy? Typically, there's a dedicated ostomy team at most hospitals that will help you and see you on a daily basis to teach you and your family how to take care of the ostomy. They will facilitate getting you started with an ostomy supplies after leaving the hospital. They are also available on an outpatient basis for problems that may arise after leaving the hospital. Additionally, there are many local and national support groups available for patients with ostomies. What if the cancer has spread? Some patients have cancer that is not causing a bowel blockage, but has spread to other areas of the body. In this situation, chemotherapy is typically given to kill the cancer cells. If the cancer has spread but is also causing a bowel blockage, surgery may be done to relieve the blockage without removing the part of the bowel containing the cancer. Instead, the bowel is cut above the tumor and attached to an opening in the skin to allow the stool to come out. This is called a diverting colostomy. It can allow the patient to recover enough to start other treatments such as chemotherapy. Despite the cancer spreading outside the colon and rectum, if the cancer has spread to only one or a few areas, such as in the lung or the liver, surgery may be used to remove it. Deciding if surgery is an option to remove the area of cancer depends on their size, number, and location. This surgery will require a lung surgeon or a liver surgeon. In most cases, this is done only if the cancer in the bowel is being removed or was already removed. The lung or liver surgery may occur before, at the same time, or after the cancer in the bowel has been removed. Chemotherapy is also given. Depending on the extent of cancer spread, this might help the patient live longer or could even potentially cure the cancer. What are the risks of surgery? Possible risk and side effects will depend on several factors, including the extent of the operation and the general health of the patient before surgery. Problems during or shortly after the operation can include pain, bleeding, infection, blood clots in the legs, and injury to other structures in the abdomen. Sometimes after colon surgery, the bowel takes longer than normal to wake up and start working again after surgery. This is called an ileus. It might be caused by the anesthesia or the actual handling of the bowel during the operation. Sometimes too much pain medicine can also slow down the bowel function. If you develop an ileus, eating solid food or liquids may be delayed, especially if you're having nausea or vomiting. Sometimes a tube is inserted into your nose to help suck out the contents of your stomach. After the surgery, sometimes many years after, you might develop scar tissue in the abdomen that can cause organs and tissues to stick together. These are called adhesions. Sometimes these result in your bowels being blocked off. This can cause pain and swelling in the abdomen that's often worse after eating. Further surgery may be needed to remove the scar tissue. Sometimes a new connection between the ends of the colon may not hold together and may leak. This is called an anastomotic leak. The figure here demonstrates a leak at the new connection. The two ends of the bowel have suture holding it together, but at the corner there is a hole where stool is leaking out of it. The risk of this happening varies based upon the location of the connection, but can be seen in about 10% of patients undergoing colon and rectal surgery. This may cause severe pain and fevers. A small leak may cause you not to pass stool, to not have the desire to eat, and not do well or recover as expected after surgery. A leak can lead to an infection inside of your abdomen that may require another procedure to drain the infection. Sometimes the leak is large enough that stool leaks into your abdomen. This can get you really sick and can require another surgery to create an ostomy as previously described. This will give your body time to recover and will help heal the leak with the goal of reversing the ostomy in 3 to 6 months. There are additional risks to surgery involving the rectum. There are a lot of nerves near the rectum that are at risk for injury during rectal cancer surgery. This figure demonstrates the nerves in yellow and then the rectum is in pink. These nerves can also be injured by radiation. If these nerves are injured, they can cause impotence and impaired ejaculation in men and vaginal dryness in females. These nerves also supply the bladder, so patients can have trouble with emptying their bladder or they may have urine that leaks spontaneously. Another risk specific to rectal cancer surgery is low anterior resection syndrome, also called LARS. LARS is a collection of symptoms that occur after removing the rectum and can be seen in 25 to 80% of patients after rectal cancer surgery. For some, the symptoms improve over the first year. For others, it may be a long-term problem. Treatment of LARS is based on the predominant symptom of each patient and can be quite variable among patients. For diarrhea predominant LARS, Imodium, which is an over-the-counter medication, is typically used. Patients with incontinence, urgency, and frequency may benefit from a serotonin receptor antagonist called remicetron. Gas pains and bloating may be caused by bacteria in the small intestine and can be treated with antibiotics. Probiotics and fiber supplementation are low risk and may be trialed, but there is little evidence to suggest it is beneficial. If the prior medications are ineffective in helping alleviate the symptoms of LARS, there are additional treatment options that may be helpful. Transanal irrigation, in which the tap water enemas are performed, may help with symptoms of fecal incontinence or frequency. These patients may also benefit from pelvic floor rehab, in which the patient retrains their pelvic floor muscles, which help control stooling. Patients who have persistent symptoms despite all these treatments may be considered for sacral nerve stimulation, which is a device implanted in the buttocks area and stimulates the pelvic nerves. The figure on the right demonstrates a sacral nerve stimulator in the patient's buttocks. If all other treatments have failed, the patient may be considered for permanent fecal diversion with an ostomy. What happens after surgery? When you wake up from surgery, you'll be in the recovery room and then you'll be transferred to a room in the hospital. You'll be in the hospital on average 3 to 5 days for laparoscopic or robotic surgery and 5 to 7 days for open surgery. Most hospitals will have a post-surgery pathway called an ERAS pathway that has been shown to improve patient outcomes. This pathway focuses on pain control. There are a variety of treatment options available to minimize the use of pain medicines after surgery. Pain medicines can slow your bowels down after surgery, so it's best to minimize if possible after surgery. I typically do pain blocks in the operating room called tap blocks to help with postoperative pain. Other medications I use are Tylenol, ibuprofen, or Toradol, which is an IV version of ibuprofen, and a nerve medicine called Lyrica. When used in combination, they can significantly reduce the amount of pain medications needed. You may be given medications before you have surgery by the anesthesia team to help minimize nausea after surgery. You will also have anti-nausea meds available after surgery. Typically, you'll be given a clear liquid diet on the night of surgery and will be advanced to a regular diet the day after surgery if you are doing well. I recommend low fiber foods for the first 2 weeks after surgery to minimize abdominal bloating and cramping. The more active you can be in the hospital, the quicker you will recover from surgery. I recommend sitting in the chair throughout the day and taking multiple walks throughout the day. This will also help prevent blood clots from developing. In addition to staying active, we will also give you blood thinners to help prevent these blood clots, and will sometimes discharge you home on these blood thinners. I would be happy to answer any questions, and I thank you for taking the time to listen to this webinar.
Great. Thank you so much, Dr. Chapman. So great to have a lot of really great information all in the same place, which is always nice for us to see. So yeah, just as Dr. Chapman said, please go ahead if you have any questions and go ahead and add them to the main chat box that you see next to the window here. And it looks like we've had one come in already. Lada said, I had a 30 centimeter of my sigmoid removed, diagnosis of stage 3 colorectal cancer. Could that be the reason why my stool is narrow like a finger?
Correct. Yeah. So as the cancer develops in the sigmoid colon, it narrows the lumen or the diameter of the colon. And so that causes a narrowing of your stools.
Great. It looks like Cheryl said a minimized fiber for how long after surgery?
I typically do it about 2 weeks. That gives your body time to recover from the surgery. And then when you reintroduce fiber, you want to start slow. If you go too fast with it, it can really make you bloated and cramping.
Great. Well, some people are maybe adding some more questions. I have a couple for you that I can throw in there to get things going. Yeah. So one of the things that we hear a lot about, especially in the recovery, is people asking, like, what do you need to have set up at home to make sure, once you are discharged, that you have things set up for the best success and outcomes possible once arriving back at home. Do you have any suggestions that that have been successful for patients that you've had?
Yeah, I think just being prepared before you go into surgery, a good family or friend support is very helpful. When you go home, you'll be able to do most of your activities of daily living, take care of yourself, but it's always nice to have an extra hand, or if you need to get something at a grocery store, have a friend or a relative available to do that. One of the things that is really helpful to have if you do have to have an ostomy is to get that set up in the hospital before you go home. We typically send patients home with wound care or ostomy care, where they provide some support to help get you through those initial first few days or weeks.
And Tina's asking here, can you touch on reversal surgery? Is the risk of infection high, and do you give antibiotics before that surgery as well?
Yeah, it'll depend on the type of ostomy that you have. It's a little bit different, whether it's the small intestine, where it's an ileostomy, versus the large intestine, which is called a colostomy. So typically for the ileostomy, the reversal process is much easier, and we try to favor doing those if we can. The reason why is most of the time we don't have to re-enter the abdomen. We make an incision around that ostomy, and we're able to re-hook up the two ends of the bowel together, and then we dunk it back in. The colostomy takedown, it's a bigger surgery, and it usually requires you going back into the belly, either robotically, laparoscopically, or sometimes an open surgery to reconnect those ends. Both of those are at risk for a wound infection after. So For the colostomy takedowns, we'll do the same bowel prep and the antibiotics the night before, and then we give you another round of antibiotics through an IV at the time of surgery. The biggest thing is where that ostomy was, it's been sitting in stool, so those are at risk for a wound infection after surgery. So most of us will intentionally not close that skin tight and allow any infection or bacteria there to evacuate itself. So it takes a little bit of a longer time for that wound to heal, but it heals remarkably well and quickly despite not closing it tight.
It's interesting. Yeah. And then Catherine has asked here, why is Lars not discussed after surgery is performed?
Well, I think as surgeons, we need to be more vocal about Lars. It's one of those things that can be very challenging to treat after surgery. So it is important to have the surgeon discuss that with the patient and the potential possibilities. It's hard to predict who's going to develop those symptoms, but I would say the lower down on the rectum the cancer is, the more likely you are to develop those symptoms. But I agree that we should be talking about it much more frequently than we probably do.
Now, could you touch on recurrence stats on rectal cancer and what symptoms to watch for?
Yeah, so after you're diagnosed with colon or rectal cancer and you go through the surgery, we follow you very closely in the next 5 years. Most recurrences happen within that first 2 years. So there's a lot more frequent surveillance. You'll be getting blood tests every 3 to 6 months. You'll be getting CAT scans about every 6 months. You'll get another colonoscopy at a year. And then depending on what they see at that 1 year, the most likely thing is you'll get another colonoscopy at 3 and then 5 years. So we're very close in following you to make sure that if it does recur, we try to catch it sooner.
Right, kind of even going back to when we were talking about Lars, what are some other what are some questions that all patients should be asking their surgeons before surgery? We covered a lot of different things, but I'm sure that there's some greatest hits, some heavy hitters that you know that we want that you know people should be asking when they have a meeting with their surgeon.
Yeah, I think it's just talking about the expectations of surgery, the recovery process, what the likelihood of you needing to get an ostomy. If you do need an ostomy, is it going to be a permanent thing or is it going to be reversible, and the typical time course of it? And then just like what to expect after surgery, what do you need to look for, fevers, chills, abdominal pain, things of that nature. And then it's really good if there's a high likelihood of needing an ostomy. Getting set up with the ostomy team before surgery can be really helpful for the patient to start to learn how to take care of it. Because after surgery, everything's really overwhelming. And so by learning it a little bit before the surgery, that can help some of that, the questions after surgery.
Sure, yeah, that makes sense. This is really great. Well, please keep entering your questions in here if you have any questions. And then once we're out of questions, we're still gonna keep this area open. That's one of the neat things about this hop-in platform is you can all meet each other. There's the opportunity to use the little networking function on the side. Looks like 2 hands shaking over to the left where you can meet with someone else one-on-one. But I have a couple more for Dr. Chapman. So please just enter your questions in if you have them. One of the other things that I wanted to ask about is when really you're thinking about the different complications that could exist, and you were talking about all those different things. Is there anything, if you're working with a nurse or someone else on your care team that they can help you with that are other supportive resources, that you know of, that because not everyone has a large care team. Some people are living in rural areas, some people don't have as much access, but who should they be looking for that's really the surgeon's best right hand man or woman who's the the best supporter of the work that you do as a surgeon?
Yeah. So there's a lot of important people involved with having surgery and having a good recovery process. The nurses are essential in facilitating the communication from the patient to the surgeon, just because we're not there all day like they are. So they're very good at with the communication. Case managers are really good, or social work, to help facilitate things getting set up for home. Is there a need to go to a rehab after surgery? Do I need to go home with ostomy supplies? And they can help get that set up. And then if you're in teaching hospitals like we are here at the University of Colorado, residents are very good and actively involved and can help facilitate some of these processes.
Fantastic. Thank you. I have another one come in here. I have massive sessile polyps throughout all parts of the colon. Last colonoscopy revealed a sigmoid polyp 25 centimeters. They are not malignant at present time. I'm urged to have a small part of the intestines and all of large intestines and rectal surgery. If not yet malignant, would you still recommend the surgery now, or is having colonoscopy sufficient once a year in your opinion? And you can answer that as best you can.
Yeah, it's a little bit hard to know without actually seeing the polyps and how many there are. I would talk to whoever's doing your colonoscopies to see how comfortable they are knowing that they got all the polyps out at that time. And at some point too, if there's so many of them, maybe just a discussion between you and your surgeon and the GI doctor. At what point do we start to say, I'm getting this done every year? Is it better if I just take out the colon? But taking out the colon is a big deal too. So we try to avoid doing it if we can manage these endoscopically. And I do think that over the last years, we've been more aggressive in treating these adenomas endoscopically that used to require bigger operations. So I think that's a good discussion with your endoscopist, and make sure he's comfortable with keep on removing these polyps and just keeping a close eye on it so it doesn't go too long and develop into a cancer.
All right. Well, looks like we haven't had any other questions come in. So I'd like to thank you once again for joining us, Dr. Chapman. And also thank you to our sponsors for this webinar, No Shave November and Genentech. If any of you still have questions or think of something later, feel free to email info@fightcrc.org, and we can look at getting the answer for you or helping direct you to someone who can. So thank you all for being here. Like I said, this hop-in platform will stay open even after we stop broadcasting here. You all can chat with each other, meet each other, use that networking function, take advantage of it while you got the chance. So thank you for joining us today, and we'll see you again next time. Take care, everyone. Oh, looks like we had one last one come in. So let's go ahead and tackle that before we get going.
Sure.
Let's see, given the percentage of statistics, which is not that big to develop rectal cancer, are you seeing any genetic similarities?
So what we're seeing in the United States anyways is younger and younger people being diagnosed. So the actual incidence in the older population of colorectal cancer is going down, but it's going up in the younger population. Why it's going up in the younger population, we're not entirely sure why. I'm sure there's a little bit of component of environmental and diet and exercise in addition to genetic changes. But in general, the genetics syndromes that result in colon and rectal cancer are pretty low. I think that accounts to only about 5% of colon and rectal cancers. So still pretty low, but we're seeing it in the younger population.
All right, excellent. Glad we got that last one in there. So as I see Elizabeth put in the chat there, info@fightcrc.org for any additional questions. All right, everybody, have a great day. Take care.
Thank you.